Welcome to the deep dive. Today we'll be rapidly reviewing abdominal wall anatomy for plastic surgery residents preparing for the FRCS plastic exam.
Absolutely. Having a solid understanding of this anatomy is crucial for both the exam and safe surgical practice.
Okay, let's jump right in, starting with the layers of the abdominal wall. There are 7. But why should we care about this as plastic surgeons?
Well, it's not just about being able to list them. It's about really understanding the clinical significance of each individual layer. For instance, take the two distinct fat layers. They have different blood supplies. The superficial layer has a richer blood supply, so thinning it during an abdominoplasty is risky. You risk compromising the skin's viability. The deeper layer, however, is mainly supplied by the subdermal plexus and perforators, so you can excise it more safely during flap thinning.
That makes sense. Understanding those small details can really affect how you approach a surgery. Okay, on to the muscles. There are 4 key paired muscle groups in the abdominal wall: rectus abdominis, external obliques, internal obliques, and the transversus abdominis.
And it's actually their aponeuroses that are especially important when it comes to shaping the abdominal wall and creating the structures we work with surgically. So these aponeuroses form the rectus sheaths, which enclose the rectus abdominis muscles, and they meet at the midline, forming the linea alba.
And about the rectus sheath, there's a significant anatomical transition point we have to be aware of.
Right, that's the arcuate line. Above this line, you have clear anterior and posterior rectus sheaths. But below the arcuate line, the aponeuroses of the internal oblique and transversus abdominis actually fuse with the external oblique aponeurosis, which creates a single anterior sheath. And below the arcuate line, there's no posterior sheath. So you got to picture how those layers change. It's a favorite spot for examiners to focus on.
Yeah, definitely. That transition can be a bit tricky. Now, shifting gears to vascular supply. Huger's classification is a must-know for the FRCS plast. Can you break it down for us?
Sure. Huscher divides the abdominal wall blood supply into 3 zones. So zone 1 is contained within the lateral borders of the rectus sheath. It goes from the costal margin down to a line drawn between the ACES, the anterior superior iliac spines. This zone is supplied by the superior and inferior epigastric vessels. Zone 2 is below that line between the ACES and extends down to the pubic and inguinal creases. It gets its blood supply from branches of the circumflex iliac and external pudendal vessels.
And lastly, there's zone 3.
Yeah, Zone 3 sits above Zone 2 and lateral to Zone 1, and its blood supply comes from the intercostal, subcostal, and lumbar vessels. Make sure you can visualize these zones on a diagram. Figure 100-2 from your source material is a good reference. It's super important to understand the zonal anatomy when planning incisions and flaps during surgery.
Right, it always comes back to how it affects us in surgery. Moving on to nerves. The abdominal wall is primarily innervated by the intercostal nerves, specifically T7 to T12.
Yeah, the lateral cutaneous branches have a pretty straightforward path. They pierce through the intercostal muscles and run within the subcutaneous plane. The anterior cutaneous branches, on the other hand, take a more winding route. So they travel between the transversus abdominis and internal oblique muscles, then penetrate the posterior rectus sheath before actually entering the rectus muscle itself, and finally emerging to supply the skin.
Of all the nerves, the lateral femoral cutaneous nerve deserves special attention.
Absolutely. This nerve emerges near the ACES and it innervates the skin on the lateral thigh. Its location actually makes it susceptible to injury during abdominoplasty. So preserving a layer of fat over the ACES during surgery helps protect it. This is key for patient safety.
Definitely a high yield point for the exam. Now let's tackle the umbilicus. It's a frequent focal point in abdominoplasty.
And contrary to what some might think, a perfectly midline umbilicus is actually pretty rare. Studies show that only about 1.7% of patients have one.
So what makes an umbilicus aesthetically pleasing? What should we be aiming for surgically?
Well, ideally, an umbilicus exhibits features like superior hooding, inferior retraction, a generally round or elliptical shape, and a shallow depth. You also need to think about the blood supply, which comes from the subdermal plexus, the deep inferior epigastric arteries, the ligamentum teres, and the median umbilical ligament. Figure 100-4 in your source material provides a good visual.
Any other key points about the umbilicus that residents should remember for the FRCS plast?
Remember that the umbilicus is a potential site for complications like poor healing or malpositioning. This is especially important to discuss with patients preoperatively. They need to have realistic expectations.
Excellent point. Now let's shift gears to the preoperative evaluation for abdominoplasty. What are the absolute must-ask questions when taking a patient's history?
We need a complete picture of the patient's abdominal history. So this includes pregnancies, previous abdominal surgeries like cesarean sections, any history of hernias, their exercise routine, and their overall gastrointestinal and respiratory health. And of course, their weight history is critical. We need to understand patterns of weight loss and gain, any current diets they're following, and any history of weight loss surgery.
And we definitely can't forget about smoking.
Absolutely. Smoking significantly impacts wound healing, and abdominoplasty puts stress on the abdominal wall flex blood supply. Operating on smokers dramatically increases the risk of complications. So we need to be very clear about the risks and insist on smoking cessation before surgery. We might even need a urine or blood nicotine test in some cases.
Okay, moving on to the physical exam. What are the red flags or key findings that we need to be aware of?
First, we examine the skin for striae. Striae below the umbilicus can potentially be removed during the procedure, but those above the umbilicus likely won't be, and they might even become more prominent after surgery as the skin is stretched, so we need to explain that to the patient.
Accurately assessing excess skin is critical too.
Yes, definitely. Examine the patient standing, supine, and sitting. Each position can reveal different things about the excess skin. And look for rashes or excoriations, particularly under the pannus in obese patients or those with massive weight loss. Also, pay attention to any adhesions where the skin is tethered to deeper structures. These are often seen at the waist. Adhesions can limit flap movement, and releasing them surgically increases the risk of ischemia.
What about scars? They could also impact the procedure, right?
Definitely. Scars change the blood supply. Upper midline scars might limit downward flap movement and might need to be released. Or a fleur-de-lis abdominoplasty might be a better option. Subcostal scars are particularly tricky because they disrupt that superolateral blood supply that's so important for healing. So patients with subcostal scars are at the highest risk for wound healing complications. And they may not even be suitable candidates for abdominoplasty.
And then there's myofascial laxity. We also need to assess that.
Right. The Divers test helps with this. Have the patient stand and then flex at the waist. If that lower abdominal wall fullness gets worse with flexion, it suggests myofascial laxity. The pinch test is helpful too. Assess the abdominal fullness while the patient is relaxed and then while they tense their abdominal wall. If there's a significant reduction in fullness with tensing, it points to significant myofascial laxity.
And diastasis recti.
For upper abdominal fullness, have the patient lie down. If the abdomen becomes scaphoid, bancolcation will be effective. But if fullness persists, bancolcation will be more challenging. Weight loss before surgery might be helpful in those cases. Keep in mind that most patients with a history of pregnancy will have some degree of myofascial laxity and excess skin. And finally, we need to very carefully examine for hernias, incisional, epigastric, periumbilical, and inguinal. This is especially important for those with previous surgeries or massive weight loss.
Thoroughness is definitely key, especially with hernias. Now let's talk about informed consent. What are the absolute essentials to cover with the patient?
They need to understand the scar placement and potential length, including the standard lower abdominal transverse scar and the possibility of needing a vertical scar forming an inverted T. Also, discuss the possibility of dog ears at the incision ends, which might require revisions. And we need to be upfront about the overall complication rate, which is around 20% to 34%, and specifically mention wound healing complications. Both the incision and umbilicus are at risk due to limited vascularity.
And smoking comes up again here.
Right. Smokers have a much higher risk of wound healing complications, almost 50% compared to around 15% for non-smokers. We also need to mention the potential for umbilical complications, such as loss or malpositioning, and remind them that a perfectly midline umbilicus is rare.
And what about seromas?
Seromas occur in about 0% to 14% of cases, so explain the purpose of postoperative drains. Be upfront about the possibility of revision surgeries, which can range from 5% to 43%.
Recovery expectations are also important.
Of course. Patients need to know that they won't be walking upright for several days, and they'll need at least 2 to 3 weeks off work. Strenuous activities and heavy lifting are off limits for at least 6 weeks.
What about the risk of pulmonary embolism?
Yeah, abdominoplasty has an increased risk because of general anesthesia and the longer operative times. All patients should wear TED hose and SCDs starting preoperatively. Early ambulation and hydration are also important. And consider using low molecular weight heparin, like Lovenox 40 milligrams subcutaneously on the evening of surgery, and continuing for 7 days.
And the risk of infection.
The literature reports an infection risk of about 0% to 8%. So following the SCIP protocol helps minimize this risk. This involves avoiding shaving, administering IV antibiotics 30 to 59 minutes before the incision, continuing antibiotics for 24 hours postoperatively, ensuring an A1C below 7 for elective surgery, and maintaining normothermia during the procedure.
With a moderate complication rate, making sure that patients are good candidates is crucial. Okay, let's talk about procedure selection. There are several options, each suited for different patients.
Yeah, so for those with mild fat excess, no excess skin, and good skin tone, liposuction alone might be enough. If they also have rectus diastasis, combining liposuction with an endoscopic diastasis repair might be appropriate. If the excess skin and fat are limited to the area below the umbilicus, an intraumbilical mini-abdominoplasty is a good option, often with liposuction and diastasis repair. And for more significant excess skin and fat that goes beyond the infraumbilical area, a traditional abdominoplasty is preferred, maybe with liposuction of the flanks.
And what about patients with a lot of excess skin, maybe even wrapping around to the back, like what we often see after massive weight loss?
A circumferential abdominoplasty is usually the better choice in those cases. And then we have some specialized techniques like Lockwood's high lateral tension abdominoplasty for when the excess is concentrated in the lateral abdomen, hips, and thighs. This technique uses an oblique pull to address both vertical and horizontal excess. And for patients with excess skin both vertically and horizontally, especially in the upper midline, a fleur-de-lis abdominoplasty might be a good option.
Now let's dive into the specifics of a traditional abdominoplasty. Starting with preoperative markings, how do we approach this?
Before marking, it can be helpful to have the patient wear their preferred undergarments. This helps us plan the lower incision so that we can hide as much of the scar as possible. First, we identify the pubic bone and the ascis bilaterally. With the patient standing, we mark the lateral aspects of the abdominal fold. This helps us guide the lateral extent of the incision. The planned incision is marked transversely, beginning at the level of the pubic bone. Make sure there's at least 5 to 7 centimeters of space between this incision and the top of the vulva to prevent distortion postoperatively. Then, extend the transverse marks laterally and upward towards the hips, making sure that the lateral almost points are below the ascisses. This keeps the scars hidden.
Okay, and how do we figure out how much skin to actually remove?
We use a pinch test. It helps determine how much skin we can comfortably remove while still allowing for a tension-free closure. So this guides the design of the proposed upper incision. If there's any doubt about reaching the umbilicus with the upper incision, we need to discuss with the patient the likelihood of needing a small vertical component, resulting in an inverted T-shaped scar. Also, preoperatively, we should mark any areas for potential liposuction. A lot of patients seeking abdominoplasty also have excess fat in the hips, flanks, or thighs. And these deposits often become more noticeable after the procedure, so we should consider doing liposuction at the same time or doing it later in stages for the best results. If we don't address this preoperatively, it can lead to a result that the patient is unhappy with.
Okay, makes sense. Now on to the actual principles and technique of the traditional abdominoplasty. What are the key steps involved in this procedure?
Well, before the patient even enters the OR, we need to make sure that the operating table can flex at their waist to an optimal level. This will prevent difficulties during the procedure, and once the patient is under anesthesia, we perform liposuction in all the mark areas. It's important to maintain normothermia throughout the procedure, using warming blankets, thermal caps, and warm IV fluids.
And what about preventative measures for DVT and infection?
So we apply SCDs and TEDHRs preoperatively. We also administer 5E antibiotics like Ancef or clindamycin if they're allergic to penicillin. We give it 30 to 59 minutes before the incision to reduce infection risk. We also need to avoid shaving the surgical site for at least 2 weeks prior to surgery and prohibit the use of razors. Clippers can be used if absolutely necessary. And make sure the umbilicus is thoroughly cleaned before starting the procedure. The patient should be instructed to clean it with surgical soap and cotton-tipped applicators a week before surgery.
And what are the first steps of the abdominoplasty itself?
So we start by placing 2 traction sutures at the 3 o'clock and 9 o'clock positions on the umbilicus. We use asymmetrical tails on these sutures to prevent twisting of the umbilical stalk during closure, which could compromise blood flow. Then, we make a circular incision around the umbilicus, and we use dissecting scissors to separate it from the surrounding skin and fat, going down to the rectus sheath. Try to avoid excessively skeletonizing the umbilical stalk. This helps to preserve its blood supply. Next, we make the bilateral lower incisions and dissect straight down to the fascia covering the rectus and oblique muscles. Then, elevate the skin and fat of the abdominal wall from the underlying muscle fascia. We work in a loose areolar plane, going up to the costal margins laterally and the xiphoid process medially.
And how do we make sure that we preserve the blood supply to the abdominal wall during undermining?
Limiting undermining to the central area that's needed for rectus plication helps preserve most of the blood supply. We also want to leave a thin layer of fat on the muscle fascia near the ACIS to protect the lateral femoral cutaneous nerve. As we dissect centrally along the muscle fascia, we need to carefully identify and protect the umbilical stalk to prevent severing its blood supply. The presence of a lot of myocutaneous perforating vessels around the umbilicus should alert us to the proximity of the umbilical stalk.
Okay, that makes sense. So once we've done the initial dissection, how do we determine the final amount of skin and fat to be removed?
Once the initial dissection is done, we flex the operating table to bring the patient into a seated position. This lets us mark the amount of skin and fat that can be safely taken out while still being able to close the wound without too much tension. Then, we cut out the marked excess tissue, irrigate the wound thoroughly, and move on to repairing the rectus diastasis.
Okay, so how do we do the rectus diastasis repair?
First, we use a cotton-tipped applicator dipped in methylene blue to mark the elliptical area on the rectus sheath that we're going to imbricate. Then, we place interrupted sutures along the marked area to imbricate or reinforce the rectus sheath. Rectus duplication helps to narrow the waist and address the abdominal wall laxity that's often present in women who have had children.
Are there any other techniques we can use to make the repair stronger?
After placing the first row of interrupted permanent sutures, a second reinforcing permanent suture can be run from the xiphoid process to the umbilicus, and a separate reinforcing suture from below the umbilicus to the pubis. Horizontal plication sutures can also be added to further narrow the waist. And remember to start the rectus plication just below the xiphoid process. This will help avoid creating a postoperative bulge in the upper abdomen.
And what type of sutures should we use for rectus plication?
Permanent sutures are very important for long-term success. Studies using absorbable sutures have shown higher recurrence rates for diastasis. Using permanent sutures, however, has led to significantly lower recurrence rates, approaching 0% in some studies.
Are there any ways to help manage pain after the surgery?
Rectus ecplication tends to be the most painful part of the surgery. Using continuous infusion catheters to deliver local anesthetic to the plication site can really help reduce postoperative discomfort.
Now let's talk about progressive tension sutures. What are they, and what are their advantages in abdominoplasty?
Progressive tension sutures, or PTS, help secure the abdominal flap to the underlying muscle fascia, and they distribute tension across the flap rather than concentrating it on the incision. This reduces the risk of tissue necrosis and hypertrophic scarring. They also effectively close the dead space, which minimizes the chance of hematoma and seroma formation. PTS can be used in various abdominoplasty techniques, like lipoabdominoplasty, and even in other body contouring procedures. Running barbed sutures have also been successfully used as PTS.
Can you walk us through the key steps of using progressive tension sutures?
Sure. The abdominal flap is sutured and advanced onto the muscle fascia using interrupted 2-0 vicryl sutures. As you advance the flap, you apply progressive tension to each suture, pulling it away from the incision line. This helps reduce the tension on the incision, promoting better healing.
Great. Now let's talk about lipoabdominoplasty. What is this technique, and how does it differ from traditional abdominoplasty?
Lipoabdominoplasty basically combines liposuction with a modified abdominoplasty approach. First, the areas for liposuction are marked, and then the super wet technique is used. Both ultrasonic and traditional suction-assisted liposuction can be used safely. It's important to leave a thin layer of fat on the abdominal wall. This will help preserve the lymphatic system. And very importantly, we want to limit undermining to the central area where rectus plication will be done. This usually extends to the lateral border of the rectus muscle. This selective undermining approach preserves most of the blood supply, nerves, and lymphatics. This results in fewer complications like seromas, dehiscence, necrosis, and hematoma.
So basically a less invasive approach to abdominoplasty.
Exactly. It gives you the benefits of a tummy tuck with a lower risk of certain complications.
Now let's move on to mini abdominoplasty. What are the indications for this procedure?
Mini abdominoplasty is perfect for patients with excess skin and fat that's mostly located below the umbilicus.
And how does the technique differ from a traditional abdominoplasty?
So the incision for a mini abdominoplasty is shorter, usually about 12 to 16 centimeters, and the umbilicus stays attached to the abdominal wall flap. We don't separate it. Instead, the umbilical stalk is cut at the level of the anterior abdominal wall fascia, and then the resulting fascial defect is repaired. The rectus diastasis is addressed with permanent sutures, and we do a more conservative skin and fat resection compared to a traditional abdominoplasty. And the umbilicus is usually moved downward by about 2 centimeters. Liposuction is often included to further improve the abdominal contour, especially in the area above the umbilicus.
Okay, that makes sense. Moving on to high lateral tension abdominoplasty, what are the main ideas behind this technique?
This technique recognizes that while excess skin below the umbilicus is mainly vertical, excess skin in the upper abdomen is mostly horizontal. This horizontal laxity in the upper abdomen is because the superficial fascia is strongly attached to the linea alba. This restricts the vertical movement of skin and fat. So in this technique, we remove less skin centrally and more laterally. This creates an oblique pull, which addresses both the vertical excess below the umbilicus and the lateral pull in the upper abdomen. Another key principle is that we don't need to do extensive undermining up to the costal margins like we do in traditional abdominoplasty. We limit undermining to the central area that we need for rectusplication. This makes liposuction safer in a wider area of the abdominal flap. Liposuction done superolaterally creates discontinuous undermining, which then allows us to advance the abdominal flap.
So what are the benefits of this technique?
It effectively lifts the anterior and lateral thigh, improves abdominal contour through liposculpture, and offers a more aesthetically pleasing result.
Okay, and how do we mark the patient for a high lateral tension abdominoplasty?
First, mark a point about 6.5 to 7 centimeters above the vaginal opening, or the base of the penis. Then, mark the ACIS on both sides and connect the 3 points. Place the marking pen centrally at the inferior incision line and pull the excess vertical skin upward until it's taut. Mark the spot where the skin meets the tip of the pen. Now use a pinch test to check for any potential excess skin laterally and mark those areas accordingly. Connect these lateral marks to the central mark. The resulting upper incision line should be below the umbilicus centrally and above the umbilicus laterally. Mark any areas for planned liposuction, both centrally and laterally.
And can you walk us through the main steps of the high lateral tension abdominoplasty technique?
Sure. We start by making the lower incision and then lifting the skin and fat away from the rectus fascia in the middle. We only separate it enough to do the rectusplication. Then we do the rectusplication. On the sides, the abdominal skin flap stays attached to the underlying rectus fascia, but it's loosened through discontinuous undermining. We can do this using different tools, like vertical spreading or Mayo scissors, the surgeon's finger, an oversized suction cannula, or a specialized undermining cannula. We then confirm the amount of skin and fat to be removed in the center and on the sides using a pinch test or a special abdominal demarcator. Remember, we take out more skin and fat laterally than centrally in this technique. The umbilicus can be handled in a few different ways, depending on how much skin needs to be taken out below it. We can leave it in place and pull it downward, we can cut its stalk and let the umbilicus float, or we can completely remove it and relocate it. Then we'd attack the wound closed and do liposuction in both the superficial and deep layers. Drains are placed as needed. Next, we repair the superficial fascial system, followed by closure of the deep dermis and skin.
Great. Now let's talk about fleur-de-lis abdominoplasty. When is this technique the right choice?
The fleur-de-lis abdominoplasty is used when we need to remove both lower abdominal excess skin and fat through a transverse incision and excess upper abdominal skin through a vertical excision. This lets us address both vertical and horizontal excess, which is often seen in patients with massive weight loss or those with a lot of loose skin after bariatric surgery.
What are the important things to keep in mind for this technique?
The fleur-de-lis abdominoplasty can really reshape the abdomen, but it's super important to talk to the patient about the scars beforehand because they can be extensive. To keep the blood supply to the flaps as good as possible, it's crucial to keep them attached to the underlying fascia, except for the areas within the fleur-de-lis excision. The complication rate for this procedure is about the same as a traditional abdominoplasty, around 31%.
Okay, and finally, let's touch on reverse abdominoplasty. What's the rationale behind this procedure?
Reverse abdominoplasty was developed to address leftover excess tissue in the upper abdomen after a lower abdominoplasty, or for those rare patients who mainly have upper abdominal skin excess and protrusion. It involves making a transverse incision in the upper abdomen, usually at the level of the inframammary fold, and then excising the extra tissue.
Are there any specific situations where this technique is particularly useful?
Reverse abdominoplasty can be combined with breast procedures, like wise pattern reduction or mastopexy, because the inframammary fold incisions can be used for both. So that concludes our overview of the key considerations for abdominoplasty. Understanding these principles and techniques is really important for getting safe and effective results in this common procedure.
Now that we've covered the different types of abdominoplasty techniques, let's focus on some important intraoperative tips and tricks. Maintaining proper tension on the abdominal flap is essential to avoid complications. Can you talk more about this?
Sure, one of the most important ways to manage tension is using progressive tension sutures, or PTS. These sutures help distribute tension across the flap instead of it all being focused on the incision line. This reduces the risk of problems with wound healing, like dehiscence and necrosis.
Can you go over how these sutures are placed?
The flap is sutured and advanced onto the muscle fascia using interrupted 2-0 Vicryl sutures. As you advance the flap, you pull each suture away from the incision line. This creates that progressive tension.
And this technique not only helps with tension distribution, but also reduces dead space, which minimizes the chance of hematoma and seroma formation.
Exactly. PTS can be a really valuable tool in a lot of different abdominoplasty procedures. We can even use running barbed sutures as PTS.
Another important thing to remember is to protect the blood supply to the abdominal flap. What can we do to make sure this happens?
As we talked about before, limiting how much we undermine is crucial. In traditional abdominoplasty, we only need to undermine the central area where we'll be doing the rectusplication. Lipoabdominoplasty takes us even further by using selective undermining, which further minimizes disruption to the blood supply.
And during the dissection, we need to be careful around certain anatomical structures.
Right. The lateral femoral cutaneous nerve, which comes out near the ACES, is at risk during dissection. Leaving a thin layer of fat over the ACES helps protect this nerve.
And we have to be extra careful when working around the umbilicus.
Yes, the umbilical stalk needs to be carefully protected to keep its blood supply intact. We can tell we're getting close to the umbilical stalk when we see a lot of perforating vessels in the area around the umbilicus.
Okay, let's move on to postoperative care now. What are the key aspects of managing patients after an abdominoplasty?
Postoperative care is all about promoting healing, minimizing complications, and making sure the patient is comfortable. Let's break down the main components.
Okay, starting with pain management. What can we do to address the pain patients experience after this procedure?
Pain management is really important for patient comfort, and so they can start moving around early. We usually use a multimodal approach, which means combining a few different pain relief methods.
What specific methods are commonly used?
We often use a combination of oral pain relievers, like opioids and NSAIDs. Patient-controlled analgesia, PCA pumps, can be used for the first few days after surgery, which lets patients give themselves pain medication as needed. Local anesthetic techniques like transversus abdominis plane, TAP blocks, can provide targeted pain relief, especially for the area where the rectusplication was done. And for some patients, we might consider epidural analgesia, particularly for those having more extensive procedures like a fleur-de-lis abdominoplasty.
And we need to make sure we tailor the pain management plan to each patient, considering things like how big the surgery was, their pain tolerance, and any other health problems they might have.
Exactly. We need to keep a close eye on patients' pain levels and adjust the pain management plan as needed.
What about wound care? How do we ensure the incisions heal properly?
Meticulous wound care is super important to reduce the risk of infection and to help the scars form nicely. We need to keep the incisions clean and dry, and teach patients the right way to clean their wounds using mild soap and water. Dressings are usually applied to the incisions, and the specific type of dressing might vary depending on what the surgeon prefers and what the wound needs.
Are there any specific types of dressings that are often used?
We often use absorbent dressings at first to take care of any drainage from the wound. Once the drainage lessens, we can use non-adherent dressings to protect the incision and minimize friction. And if there's a higher risk of infection, we might consider using specialized dressings, like those that have silver in them for their antimicrobial properties.
And when do we usually take the sutures out?
When we take the sutures out depends on what type of sutures we used and where the incision is. Absorbable sutures, which we often use for the deeper layers, dissolve on their own, so we don't need to take them out. Non-absorbable sutures, which are usually used to close the skin, are typically removed about 7 to 14 days after surgery.
Drains are also often used after abdominoplasty. What's their purpose and how are they managed?
Drains are put in to prevent fluid from building up, like seromas, which can delay healing and make the risk of infection higher. The type and number of drains we use can vary depending on how big the surgery was and what the surgeon prefers.
What are the different types of drains that are used?
We commonly use Jackson Pratt JP drains and closed suction drains. JP drains have a bulb that creates gentle suction, and closed suction drains are attached to a collection device that creates constant negative pressure. We usually leave the drains in until the drainage stops.
How do we figure out when to remove the drains?
We keep track of the amount and type of drainage closely. Drains are usually taken out when the output is less than a certain amount, often around 30 millimoles per day for 2 days in a row, but the exact criteria for taking out drains might be different based on what the surgeon thinks and how the patient is healing.
What about activity restrictions after abdominoplasty? What should we tell patients about activity levels during recovery?
It's really important to limit activity to minimize strain on the incisions and help them heal. We tell patients to avoid strenuous activities, heavy lifting, and exercises that use the abdominal muscles for several weeks after surgery.
What specific activities should they avoid?
They should avoid things like bending at the waist, lifting anything heavier than about 5 to 10 pounds, vigorous exercise, and any movements that pull or put tension on the incisions.
And how long do these restrictions usually last?
It depends on the patient and how big the procedure was. But in general, we tell patients to gradually increase their activity levels over a few weeks, starting with light walking and then moving on to more demanding activities as they can tolerate them.
When can they usually go back to their normal activities, including exercise?
Most patients can go back to work and do light activities in about 2 to 4 weeks. But they should avoid strenuous activities, like heavy lifting and intense exercise, for at least 6 to 8 weeks. It's really important to tell patients to pay attention to their bodies and avoid anything that causes pain or discomfort.
Are there any specific exercises or activities that can help with recovery?
We encourage patients to start walking at a gentle pace early on in recovery. This helps improve circulation and prevents blood clots. Once their surgeon gives them the okay, patients can start with light exercises that don't strain the abdominal muscles, like walking uphill using an elliptical trainer or doing upper body exercises with light weights. As they get stronger, they can gradually add core strengthening exercises. This helps rebuild abdominal muscle strength and support.
What about compression garments? How do they help in post-operative care?
We often use compression garments, like abdominal binders, after abdominoplasty. They provide support to the tissues, help reduce swelling, and help contour the abdomen.
How long should patients wear these garments?
We usually tell patients to wear the compression garment all the time for the first few weeks after surgery. They can take it off to bathe. After that, they can wear it for a few more weeks during the day and gradually reduce the wearing time as they heal.
So what are the benefits of wearing a compression garment?
Compression garments help reduce swelling, improve blood flow, and minimize the risk of seromas. They also give support to the tissues, which can help with comfort and allow patients to start moving around sooner. And the compression helps shape the abdomen and make it smoother.
What about follow-up appointments? How often should patients be seen after surgery?
Regular follow-up appointments are really important to check on how they're healing, address any concerns, and make sure they get the best outcome. How often these appointments happen might vary depending on the patient and how complicated the procedure was.
What usually happens during these follow-up visits?
During follow-up visits, the surgeon will look at the incisions, assess how they're healing, remove sutures if needed, and watch for any signs of complications. They'll also address any questions or concerns the patient has. We need to encourage patients to tell us about any unusual symptoms or worries they have between their scheduled appointments.
What are some potential complications that patients should know about after abdominoplasty?
Abdominoplasty is generally a safe procedure, but complications can happen. It's really important that we tell patients about these potential complications and what to look for so they can get medical help right away if they need it.
What are some of the most common complications?
Some of the most common ones include seroma formation, hematoma, infection, wound dehiscence, skin necrosis, delayed healing, bad scarring, and changes in sensation. And then there are less common but more serious complications like deep vein thrombosis, DVT, pulmonary embolism, PE, and problems with anesthesia.
Let's talk about some of these complications in more detail. Seroma formation, which is when fluid collects under the skin, is a fairly common complication after abdominoplasty. What are some things that make seroma formation more likely, and how can it be prevented or treated?
Several factors can increase the risk of seromas. Things like a lot of undermining, dead space creation, not enough drainage, and disruption of the lymphatic channels. We can use techniques like progressive tension sutures, being very careful to stop bleeding, and handling the tissues gently to help minimize the risk of seromas. If a seroma does develop, we can drain it with a needle and syringe.
Hematoma, which is a collection of blood under the skin, is another possible complication. What are the risk factors for hematoma, and how is it treated?
Risk factors for hematoma include things like not stopping bleeding well enough during surgery, trauma during surgery, high blood pressure, and some medications that affect blood clotting. If a hematoma develops, it might need to be surgically drained.
Infection is a concern after any surgery. What steps can we take to prevent infection after abdominoplasty?
We can prevent infection by giving antibiotics before surgery, using meticulous surgical technique, doing proper wound care, and keeping the surgical area clean.
Wound dehiscence, which means separation of the incision, can also happen. What can lead to wound dehiscence and how is it managed?
Things that can increase the risk of wound dehiscence include too much tension on the incision, poor wound healing, infection, and some medical conditions like diabetes. How we manage it depends on how bad the dehiscence is. It might just involve wound care, or we might need antibiotics or even surgery to fix it.
Skin necrosis, or when skin tissue dies, is a rare but serious complication. What makes skin necrosis more likely and how is it treated?
Skin necrosis can happen when the blood supply to the flap is compromised. Things that can make it more likely include smoking, a lot of undermining, too much tension on the flap, and health problems that affect circulation. We treat it with wound care, removing the dead tissue, and maybe even surgical reconstruction.
Unfavorable scarring is something a lot of patients worry about when having an abdominoplasty. What are some things that affect how scars form, and how can we get the best scar outcomes?
Genetics, skin type, the surgical technique, how much tension there is on the incision, and how we take care of the wound after surgery all play a part in how scars form. Techniques like careful suturing, minimizing tension on the incision, and proper scar management can help improve how the scars look.
Changes in sensation, like numbness or tingling, can happen in the abdominal area after abdominoplasty. Is this temporary or permanent?
Usually changes in sensation are temporary and get better over time as the nerves heal, but sometimes the sensory changes can be permanent.
And finally, we need to be aware of the rare but serious complications of DVT and PE. What signs and symptoms should we be looking for, and how do we prevent and treat these conditions?
DVT is a blood clot that forms in a deep vein, usually in the legs. PE happens when a DVT breaks off and travels to the lungs, blocking blood flow. Signs and symptoms of DVT include pain, swelling, redness, and warmth in the leg where the clot is. Signs and symptoms of PE include shortness of breath, chest pain, coughing up blood, and a fast heart rate.
And how do we prevent and treat them?
To prevent DVT and PE, we tell patients to start walking around as soon as possible, wear compression stockings, use pneumatic compression devices, and sometimes take blood thinners. Treatment usually involves blood thinners to stop the clot from getting bigger and to prevent it from traveling.
It's really important that we teach patients about these potential complications and stress how important it is to get medical help right away if they experience any worrisome symptoms.
Absolutely. Recognizing and treating problems early is key to minimizing their impact.
Okay. This wraps up our discussion of postoperative care and potential complications of abdominoplasty. By understanding these things, we can provide thorough care to our patients and help them get the best possible outcomes.
The incision for a mini abdominoplasty is shorter, usually about 12 to 16 centimeters, and the umbilicus stays attached to the abdominal wall flap. We don't separate it. Instead, the umbilical stalk is cut at the level of the anterior abdominal wall fascia, and then the resulting fascial defect is repaired. The rectus diastasis is addressed with permanent sutures, and we do a more conservative skin and fat resection compared to a traditional abdominoplasty, and the umbilicus is usually moved downward by about 2 centimeters. Liposuction is often included to further improve the abdominal contour, especially in the area above the umbilicus.
Okay, that makes sense. Moving on to high lateral tension abdominoplasty, what are the main ideas behind this technique?
This technique recognizes that while excess skin below the umbilicus is mainly vertical, excess skin in the upper abdomen is mostly horizontal. This horizontal laxity in the upper abdomen is because the superficial fascia is strongly attached to the linea alba. This restricts the vertical movement of skin and fat. So in this technique, we remove less skin centrally and more laterally. This creates an oblique pull, which addresses both the vertical excess below the umbilicus and the lateral pull in the upper abdomen. Another key principle is that we don't need to do extensive undermining up to the costal margins like we do in traditional abdominoplasty. We limit undermining to the central area that we need for rectusplication. This makes liposuction safer in a wider area of the abdominal flap. Liposuction done superolaterally creates discontinuous undermining, which then allows us to advance the abdominal flap.
So what are the benefits of this technique?
It effectively lifts the anterior and lateral thigh, improves abdominal contour through liposculpture, and offers a more aesthetically pleasing result.
Okay. And how do we mark the patient for a high lateral tension abdominoplasty?
First, mark a point about 6.5 to 7 centimeters above the vaginal opening, or the base of the penis. Then, mark the ACIS on both sides and connect the 3 points. Place the marking pen centrally at the inferior incision line and pull the excess vertical skin upward until it's taut. Mark the spot where the skin meets the tip of the pen. Now use a pinch test to check for any potential excess skin laterally and mark those areas accordingly. Connect these lateral marks to the central mark. The resulting upper incision line should be below the umbilicus centrally and above the umbilicus laterally. Mark any areas for planned liposuction, both centrally and laterally.
And can you walk us through the main steps of the high lateral tension abdominoplasty technique?
Sure. We start by making the lower incision and then lifting the skin and fat away from the rectus fascia in the middle. We only separate it enough to do the rectusplication. Then we do the rectusplication. On the sides, the abdominal skin flap stays attached to the underlying rectus fascia, but it's loosened through discontinuous undermining. We can do this using different tools, like vertical spreading or Mayo scissors, the surgeon's finger, an oversized suction cannula, or a specialized undermining cannula. We then confirm the amount of skin and fat to be removed in the center and on the sides using a pinch test or a special abdominal demarcator. Remember, we take out more skin and fat laterally than centrally in this technique. The umbilicus can be handled in a few different ways, depending on how much skin needs to be taken out below it. We can leave it in place and pull it downward, we can cut its stalk and let the umbilicus float, or we can completely remove it and relocate it. Then we'd attack the wound closed and do liposuction in both the superficial and deep layers. Drains are placed as needed. Next, we repair the superficial fascial system, followed by closure of the deep dermis and skin.
Great. Now let's talk about fleur-de-lis abdominoplasty. When is this technique the right choice?
The fleur-de-lis abdominoplasty is used when we need to remove both lower abdominal excess skin and fat through a transverse incision and excess upper abdominal skin through a vertical excision. This lets us address both vertical and horizontal excess, which is often seen in patients with massive weight loss or those with a lot of loose skin after bariatric surgery.
What are the important things to keep in mind for this technique?
The fleur-de-lis abdominoplasty can really reshape the abdomen, but it's super important to talk to the patient about the scars beforehand because they can be extensive. To keep the blood supply to the flaps as good as possible, it's crucial to keep them attached to the underlying fascia, except for the areas within the fleur-de-lis excision. The complication rate for this procedure is about the same as a traditional abdominoplasty, around 31%.
Okay, and finally, let's touch on reverse abdominoplasty. What's the rationale behind this procedure?
Reverse abdominoplasty was developed to address leftover excess tissue in the upper abdomen after a lower abdominoplasty, or for those rare patients who mainly have upper abdominal skin excess and protrusion. It involves making a transverse incision in the upper abdomen, usually at the level of the inframammary fold, and then excising the extra tissue.
Are there any specific situations where this technique is particularly useful?
Reverse abdominoplasty can be combined with breast procedures, like Wise pattern reduction or mastopexy, because the inframammary fold incisions can be used for both. So that concludes our overview of the key considerations for abdominoplasty. Understanding these principles and techniques is really important for getting safe and effective results in this common procedure.
Great. That wraps up this episode of the Deep Dive on Abdominoplasty for the FRCS PLAST exam. We hope you found it helpful.
Best of luck with your exams.